So we had a really fantastic session here at BTOG on stage 2 and stage 3 non-small cell lung cancer. It's a very topical area. There's been a lot of recent innovations over the last number of years, particularly with the neoadjuvant chemoimmunotherapy and now perioperative chemoimmunotherapy. I mean, a great discussion. One of the keynote speakers, of course, was Professor Solange Peters from Lausanne in Switzerland, and she gave a fantastic overview of the current evidence to date and, of course, emerging evidence. And one of the key take-home themes, obviously, chemoimmunotherapy is better than surgery alone, or chemotherapy with surgery is better than surgery alone. But the key question is just doing preoperative chemoimmunotherapy as good as, or indeed, equivalent to giving chemoimmunotherapy before and after surgery? That's the question we really don't know. Of course, the evidence suggests that more is probably better, and there are some recruiting trials that are, and I think that's an area of development that we will see over the next number of years. Other themes we discussed was the definition of operability. When we're deciding whether a patient with stage 3 non-small cell lung cancer should either have neoadjuvant chemoimmunotherapy or indeed go down the track of concurrent chemoradiotherapy, we have to say, is the patient operable or not? And there's been a lot of debate about what operability is, how you define it, how do you apply a consistent approach to operability for that particular group of patients. The EORTC have published guidelines. We discussed this in the session about their applicability to routine practice, and I think they are the best evidence that we've got. We all acknowledge that we needed a better concrete steer or some better variables or better patient descriptors or tumor descriptors as to what is operable but not operable to get that decision right for patients. We also discussed that for what do you do if a patient has had neoadjuvant chemoimmunotherapy and unfortunately their disease has either progressed or they themselves have become inoperable owing to medical complications. Should you do radiotherapy afterwards? Should you do chemoradiotherapy? And there's been a range of approaches that have been used. Here in the UK, we've tended just to give radiation alone, but it seems that international colleagues elsewhere are using concurrent chemotherapy or concurrent chemoradiotherapy followed by Pacific-style durvalumab, and those are very interesting options. And it raises the question, perhaps we need a study to see what is the best approach for those patients, and it's about 20% who've unfortunately progressed after neoadjuvant chemoimmunotherapy. One last very interesting topic that came up is the use of post-operative radiation therapy. We have had a number of studies, including the Lung Art study, which has all have been negative, suggesting that using radiotherapy after surgery to improve outcomes doesn't improve survival for patients. It certainly reduces the risk of disease relapsing, but probably because of the toxicity from radiotherapy to organs such as the heart, that it has reduced the survival outcome for patients. Now, since that trial has finished and recruited, our radiotherapy techniques have got much better. We're a lot better at shaping the radiotherapy dose as to where we want. And it seems that some people are using post-operative radiotherapy increasingly so, and there is indeed a phase 2 study recruiting in Canada. And I think it's not long before you can envisage that we may need to go back to that topic and think of a phase 3 study, perhaps out of the UK.